We will start now. Dr. John,
Okay.
we will start now. Okay, I will introduce. I will introduce. It is my great honor and pleasure to have today our great iconic Professor Dr. John Doyle for his distinguished and amazing subject, which is obesity and obstructive sleep apnea. This is one of our daily practice challenge. Of course, after this lecture, we will have a very easy way to manage such difficult cases. It is my honor and pleasure to have you today, Dr. John. Welcome.
Thank you very much for the kind words. And
yes,
I'm looking forward to this presentation. I'll just go to screen share and share my screen. And hopefully everyone can see my slides. Is that all good? So today's presentation, anesthesia on the obese patient, will deal, of course, with the obese patient as well as the patient with obstructive sleep apnea, because the two are very commonly found together. If you want a copy of this slide set for your own education and teaching, write to me at djdoyle@hotmail.com, and I'd be glad to send you a copy. There's 142 slides in the collection, so it's fairly big, and it could be very useful for those of you who are teaching, because it would be good for the classroom. I, as you know, have retired from Cleveland Clinic, but I still work from time to time. I'm doing mostly research and writing now, as well as some travel. This is the main building for Cleveland Clinic, and this is the biggest patient we ever saw at Cleveland Clinic. This patient weighed 445 kilograms and came for a tracheostomy, one of the most difficult anesthetics and one of the most difficult surgical procedures that was carried out because of the difficulty in establishing an airway. So we have a lot of experience with the obese patient as well as the patient with difficult airways. So we have two learning objectives. Our first is to understand the unique challenges and considerations when providing anesthesia to obese patients. And the second is to identify the implications of obstructive sleep apnea in anesthetic management and develop strategies to mitigate the associated risks. And as you know, obstructive sleep apnea is very commonly found in the obese patient. So more in learning objectives, describe the pathophysiology of obesity, the obesity paradox, which I will cover in some detail, describe how obesity impacts on perioperative care, describe the optimal airway management of obese patients, and describe the optimal ventilation of obese patients. So obesity carries with it a number of potential problems. Among the most important, reduced functional residual capacity, which results in early desaturation under apneic conditions. The second is that airway obstruction can occur when you're using a face mask, and you can have possible difficulty with intubation if the patient has a short neck, a large tongue, or redundant folds of oropharyngeal tissue, and we'll give some examples of that in a little while. Another problem is decreased chest wall compliance, resulting in what's effectively a restrictive lung defect, an increased degree of airway closure when the patient is supine. Surgical airways can be difficult and dangerous, as you saw with our 445 kilogram patient who required a tracheostomy. And there's always concern about risks of regurgitation, aspiration, that we'll have a chance to talk about in more detail. A number of these patients undergo surgical procedures, bariatric surgical procedures, such as the adjustable gastric band or the vertical sleeve gastrectomy, and less commonly now, the Roux-en-Y gastric bypass and the biliopancreatic diversion with duodenal switch. Most commonly, I think we see the vertical sleeve gastrectomy, but it depends at what center you're practicing at. One of the important cases that got me interested in this problem came when I was a resident, and we had a morbidly obese man going for a gastroplasty, and the patient got pentothal and succinylcholine, so you know how old this is. This was way, way before propofol was available. He couldn't be intubated. He couldn't be ventilated that well because of the obesity, but fortunately the succinylcholine wore off. The patient woke up and all was well. But the problem was, well, what are we going to do for the second anesthetic? So anesthetic number 2, which occurred a few days later, they used pancuronium for improved relaxation. But again, they couldn't intubate, they couldn't ventilate, bradycardia set in, hypoxemia set in, cardiac arrest occurred, and a coroner's inquest took place. And I learned about this case through the coroner's inquest, and that launched my lifelong interest in airway management and the obese patient. In fact, there is a society for perioperative care of the obese patient, ISPCOP as it's called, and you may be interested in learning more about it, but if you Google this information, you can get recommendations for care of the obese patient, and I will give you some of the recommendations that have been published. The World Health Organization has come up with the following classification of obesity, and obesity begins at BMI of 30. At 35, it's obese 2, and obese 3 occurs at over 40, previously called morbid obesity and still called morbid obesity in a lot of places around the world. Some definitions that I will refer you to from the European Journal of Anesthesiology are total body weight, your actual weight measured in kilograms, and your body mass index, your ideal body weight for men and for women. Obesity is defined as a BMI over 30. Morbid obesity here, depending on what source you pick, over 35 or over 40, more commonly over 40. And these are some of the terms commonly used in the literature. What's interesting about obesity is that adipocytes are far more than lipid storage vessels. People think, well, they just store fat. Well, not really, because they secrete metabolically active components, adipokines, and they attract and activate inflammatory cells, which have multisystem effects, vascular and cardiac remodeling, airway inflammation, and altered microvascular flow patterns. So they're linked to things like insulin resistance and metabolic syndrome. So you must not think that these are benign cells that have no clinical effect other than storing fat. They are metabolically active. And the illustration on the bottom left shows some of the products of the adipocytes that require consideration. So one idea is that obesity may be related to reduced dopamine receptor availability. So obese patients have reduced dopamine receptor availability compared to controls, with an inverse relationship between dopamine receptor availability and body mass index. And two ideas or hypotheses have been proposed to explain this relationship. Individuals with obesity may be born with a deficiency in dopamine receptors. Understimulation of dopaminergic reward circuits occur with overeating as a compensation. The alternative explanation is that dopaminergic activity is initially normal, but becomes downregulated as a result of chronic overstimulation of dopaminergic pathways. So these are two hypotheses that remain active. One thing that's interesting, particularly to Americans, is why the French don't get fat and the Americans do. So on the left, we can see a cartoon, and it says they stopped eating because the food no longer looks good, says the Frenchman with a cigarette in his left hand. And on the right, we see the American. He says, I stopped eating because the plate is empty and the TV show is over. So obesity is more of a problem in the United States than, for example, in Paris. And that remains true to this day. And they call that the French paradox. In some studies, being overweight is associated with increased survival time, creating a U-shaped mortality curve that is counterintuitive. And if you look at the probability of death scaled here, and that's on the vertical axis, on the horizontal axis, you have underweight, normal weight, overweight, and obese. You can see that the lowest mortality rate shifts towards heavier BMIs with increasing age. And you can see the various curves here go from age 20 to age 70. So this is a bit of a paradox. Why is it that in some cases, obesity in mild forms can be beneficial clinically? It's called the obesity paradox. And although obesity has long been considered to contribute to poor surgical outcomes for technical reasons, among others, recent studies of critically and chronically ill patients suggest that overweight and obese patients may paradoxically have better outcomes than normal weight patients. And I'm going to show you some examples of this. Here is an article, The Obesity Paradox, published in Current Hypertension Report, Obesity Paradox and Cardiovascular Disease. Here's another article, The Obesity Paradox in Chronic Disease, Facts and Numbers. And I'd like to show you some of the illustrations of various curves from that. In a study by Mullen et al., patients undergoing non-bariatric general surgery, the risk of death according to body mass index exhibited a reverse J-shaped relationship. And I'll show you these curves in a minute. There was a progressive increase in the likelihood of a complication with increasing BMI class, almost entirely due to increasing rates of wound infection, which is a well-recognized common complication of obesity in patients undergoing surgery. So here, let's take a look at ICU survival. And you can see the hazard for 60-day in-hospital mortality, the hazard ratio. It dips below 1 for the overweight and obese, but increases again for the underweight and the patient who's very obese. So this is a bit of an unexpected finding, and this is called the obesity paradox. In the case of patients with heart failure, you can see the cumulative survival. The underweight and recommended patients have less well survival than the overweight and obese patients. Again, a paradox that is not fully explained, but maybe because there's a lot of patients with COPD in the underweight and recommended weight categories. So we'll see that in a minute. Now, in patients with peripheral artery disease, you can see that it occurs more frequently in the underweight and the normal patient. And there's less in the patients with severe COPD, it's less common in the patient that's obese. So excess mortality among underweight patients with peripheral arterial disease may be due to overrepresentation of individuals to moderate to severe chronic obstructive pulmonary disease. And this may explain the obesity paradox. And then if you control for COPD, you may get different results. What about the patients with heart failure? Here we look at mortality rate versus BMI, and you can see that it dips down with lowest around BMI 30 to 35 and then comes up again. So this is called the obesity paradox. But those of you who take care of obese patients recognize that there are numerous special challenges in the obese patient. IV access is obviously one of these things, positioning, particularly when we want to position them prone. Airway management can be difficult. Mask ventilation can be difficult. Intubation can be difficult. Ventilation may require high pressures because of a restrictive lung defect through the mass of the chest wall. Oxygenation difficulties because of a small functional residual capacity. A tendency to airway obstruction from obstructive sleep apnea, and we'll talk about that in more detail. And comorbid conditions like coronary artery disease, type 2 diabetes are very common. So what do you do to assess a patient preoperatively or bariatric patients preoperatively? Well, here is an outline of suggestions from the University of Florida about how they should manage the preoperative patient interview. And one of the things that they want to do is get their height, weight, BMI, their Mallampati classification shown on the bottom left, the history of obstructive sleep apnea, whether they're on CPAP or BiPAP, and in many cases, they would like a patient to have a formal sleep study to assess the level of obstructive sleep apnea where that is available. One of the things that we commonly encounter in these patients is difficult mask ventilation. And this famous study by Lageron published 23 years ago now, difficulty with mask ventilation occurs in patients with age over 55, a BMI greater than 26, so that means they're overweight or worse. Patients without teeth, something that we're all familiar with. Patients with beard, difficult to get a good mask fit, and patients that snore, and of course that's a symbol of obstructive sleep apnea. So these are predictors of difficult mask ventilation. Difficulty of intubation occurs with neck size. One study has shown that difficulty with intubation increases with neck size. And in a patient with a neck size of 40 centimeters, the odds of a tough intubation are 5%. And at 60 centimeters neck circumference, the odds increase to 35%. This, of course, is for direct laryngoscopy. And the whole situation is different with video laryngoscopy. Video laryngoscopy can be very advantageous in these patients. One of the things that we also know, again, these illustrations from the University of Florida, is that positioning of the patient can be very useful. On the left, we have a patient who is initially put down in the operating room table. And on the bottom left, we show how we can reposition the airway with the head elevated laryngoscopy position or ramped position using a multiple set of blankets. And that can make laryngoscopy and ventilation much more straightforward. And so ramping the obese patient is something we commonly do, as illustrated here on the bottom. So here is the standard positioning of the obese patient. And here we can see how they have the improved positioning using blankets under the shoulders and under the head. And that can make laryngoscopy and intubation far more straightforward. And in fact, you can get a special pillow. This is the Troop elevation pillow, and there's also the Oxford pillow that is designed specifically for this purpose. And this can make intubation more straightforward. You'll want to have a difficult airway cart in all of these situations: fiber optic bronchoscope, video laryngoscope, airway introducers, airway exchange catheters, and especially supraglottic airways, of which the iGel is among my favorites. It'll depend on what resources you have available, but you want to have this readily available in case difficulties are encountered. Video laryngoscopy using, for example, the glide scope can be useful. Here is the glide scope that we used when it was originally introduced at Cleveland Clinic 20 years ago now, in 2003. Here is a picture of me intubating someone. This was 20 years ago. And you can see I am intubating the patient looking at the video laryngoscope, which is on the right. And then here I'm introducing some of the students, as well as some of my staff in white, students in blue, and how to do intubation with video laryngoscopy. And now it's pretty much the standard of care, especially for the obese patient. Here is a comment that we produced shortly after we got experience with video laryngoscopy using the glide scope. We found that successful endotracheal tube placement usually best achieved using a stylet formed in the shape of a hockey stick, a 90-degree bend, to help ensure that the endotracheal tube would be sufficiently anterior to enter the glottis. And so here is how we would customarily use a stylet to configure the endotracheal tube in this way. Here's an example of the view laryngoscopy. This view was from the original series that we did 20 years ago. And it was in black and white. It was monochrome, but the subsequent versions of the glide scope are now in full color. One question that comes up is, should all obese patients or patients with obstructive sleep apnea get a rapid sequence induction? And here they say that rapid sequence induction is a common procedure for obese patients. And in the elective obese or sleep apnea patient with no other risk factors for pulmonary aspiration, the risks and benefits of rapid sequence induction to cricoid pressure should be weighed. If rapid sequence induction is required, succinylcholine remains the neuromuscular blocking agent of choice if there's no contraindications. Since the publication of this, the use of sugamadex to reverse rocuronium intubations has taken place, and there's many people who now use a rapid sequence induction with rocuronium, knowing that if they get into difficulty, they can instantly reverse with sugamadex. So here in this study, in a series of 150 consecutive morbidly and super obese patients, awake fiber optic intubation was used. 6 to 7% of patients, the remaining 93, 94% were induced with rapid sequence induction of propofol, orthiopentone, and succinylcholine. So more comments: should the obese patients get a rapid sequence induction? Here, this author says the decision as to whether to use rapid sequence induction or awake intubation or standard induction with hypnotic should depend on thorough airway examination and comorbidity, and not based solely on whether morbid obesity is present or not. And again, they say rapid sequence inductions remains important in the morbidly obese patients with gastroesophageal reflux, diabetes, pregnancy, gastrointestinal disorders, and before emergency surgery, all of which predispose to pulmonary aspiration. However, the application of rapid sequence induction is probably not necessary in fasted patients with no further risk factors other than obesity. However, a new issue has come up with some new agents to treat obesity, and I'll talk about them in more detail. Some of these delay gastric emptying to the point where they're potentially dangerous. One thing you may encounter is obesity hypoventilation syndrome, also known as Pickwickian syndrome, characterized by hypersomnolence, right ventricular hypertrophy, pulmonary hypertension, polycythemia, hypoxemia, and hypercapnia. So it's commonly associated with obesity, known as obesity hypoventilation syndrome or Pickwickian syndrome. Now let's take a look at the lungs in these cases. The functional reserve capacity or functional residual capacity is decreased in obese patients. This reduced oxygen reserve is compounded by a larger metabolic demand, and supine total volume is often less than closing volume, so maximal pre-oxygenation is necessary in these cases. These patients desaturate very quickly. So here is an example of the various lung volumes that you remembered in your first year physiology course. And the functional residual capacity is the combination of the expiratory reserve volume and the residual volume. And when that is lowered, you have less oxygen stores. So here we have the non-obese patient on the left seeing FRC, functional residual capacity, and you can see how it is dramatically lowered in the obese patient, particularly in the obese patient who is supine and the obese patient who is in the Trendelenburg position, as we so commonly encounter in urologic procedures as an example. So remember that we also have restrictive patterns in obesity because of the mass of the chest wall, and we have obstructive patterns, especially in asthma and chronic obstructive pulmonary disease. So these various patterns may change depending on whether they got restrictive, normal, or obstructive disease. Atelectasis is another common problem. Here on the top, we have a CT scan of a normal patient on the top left awake and on the top right after anesthesia and paralysis, and you can see some atelectasis present. But in the obese patient, you can see the CT scan shows more atelectasis than would be expected in a normal patient. So there's many factors affecting mechanical ventilation in obese patients. The supine position reduces lung volumes, decreases respiratory compliance, and especially in the obese patient. Chest wall compliance decreases in obese patients since the increased abdominal girth pushes against the diaphragm, and the chest wall, of course, is heavier. Anesthesia reduces the FRC, or functional residual capacity, to approximately half of the pre-induction value in obese patients, promoting the atelectasis we saw on the previous slides. Not uncommonly, we do laparoscopic procedures in these patients, and the pneumoperitoneum from CO2 insufflation can cause systemic changes. Systemic vascular resistance is increased with increased intra-abdominal pressure, and compression of the inferior vena cava occurs at an intra-abdominal pressure of 20 millimeters of mercury, decreasing lower body venous return and decreased cardiac output. Hypercarbia and hypoxemia can be caused by ventilation perfusion mismatch because of restricted diaphragmatic mobility. And all of this means that there's potentially catastrophic complications, including absorption of CO2 that can worsen hypercarbia, acidosis, and gas emboli can be a problem with laparoscopic procedures. Pneumothorax can occur, mediastinal emphysema can occur. So one of the things that we like to do to increase oxygenation in these patients is alveolar recruitment maneuvers. An alveolar recruitment maneuver is the use of high sustained positive airway pressure to increase end expiratory lung volume and re-expand atelectatic lung areas. In non-obese patients during anesthesia, an initial pressure of at least 40 centimeters of water is needed, sustained pressure being the term critical opening pressure. To re-expand atelectatic lungs and maintain expansion, 3 conditions are required. 1, insufflation pressure must exceed the critical pressure to open collapsed alveoli. 2, inspiratory pressure must be sustained. And 3, to maintain open alveolar recruitment needs to be followed by adequate levels of PEEP, or positive end expiratory pressure. And this maneuver increases oxygenation, oxygen tension in anesthetized obese patients. So here is an example of 4 intraoperative ventilatory strategies during laparoscopic gastric banding for obese patients. PEEP was at 10 centimeters of water. The recruitment maneuver was an inspiratory pressure of 40 centimeters of water for 15 seconds. And you can see that if you do PEEP plus the recruitment maneuvers every 15 seconds, you get the best results. And so that's the result of this study from the British Journal of Anesthesia. Some clinical pearls for managing obese patients. High tidal volumes do not increase oxygenation, but increase the risk of lung injury. Suggest using between 6 and 8 mLs per kilogram of ideal body weight. Isolated use of PEEP is not effective in improving oxygenation. Alveolar recruitment maneuvers are the most effective method, as illustrated in the previous slide. And to maintain open alveoli, recruitment needs to be followed by adequate levels of PEEP, also illustrated in the previous slide. Now, at the end of the case, emergence can be a challenge. Morbidly obese patients are at higher risk of respiratory obstruction soon after extubation. It's crucial that they be fully awake, responding to commands before extubation. Extubation over an airway exchange catheter should be considered if reintubation is likely to be difficult. And this catheter is something that you probably would be familiar with. You put it in and take the endotracheal tube over it. And if you run into problems, you can reintubate over this as a guide. What about postoperative pain control? Many authorities recommend that we use multimodal pain control. That's local anesthetics, epidurals, non-steroidal anti-inflammatory drugs. Acetaminophen, as illustrated on the right, can be used, and they recommend limited use of opioids. So multimodal anesthesia for the obese patient with restricted use of opiates. Some resources that you may find useful if you are interested in bariatric anesthesia, I recommend some of these here. As well, here is a guide to perioperative management of the obese surgical patient that provides a whole pile of formulas that may be useful. And here are some guidelines that has been published about the use of guidelines for the use of thromboprophylaxis in the obese patient, showing various protocols for various patients of various weights and various kinds of drugs. One of the things that you might want to be aware of is the obesity surgery mortality risk stratification score. And if you have a BMI over 50, that's 0.1, male, score of 1, age over 45, 0.1, hypertension, 0.1, and various other risk factors like a vena cava filter, risk of 1. And you can see class A has 0 to 1 points, class B 2 to 3, and class C 4 to 5 points. And more risk of mortality comes up. So that is a useful way of identifying the risk in obesity. So some recommendations that have come out of this surgical review that I mentioned. Every hospital should nominate an anesthetic lead for obesity. Someone takes a special interest in it and make sure that it's done according to protocol. Operating lists should include their weight and body mass index. That's commonly done now. Experienced anesthesia and surgical staff should manage obese patients. Additional specialized equipment is necessary, commonly a difficult airway cart. Central obesity and metabolic syndrome can be identified as risk factors, and sleep disordered breathing and consequence should always be considered. And of course, we're going to take a look at obstructive sleep apnea in a minute. Anesthetizing the patient in the operating theater should be considered. Most of us do that, but remember in the United Kingdom, they often have induction rooms, and then they transport the patient to the operating theater from the induction room. Regional anesthesia may be recommended as desirable, but often technically difficult, although ultrasound has changed the landscape in that to a considerable degree. Robust airway strategy must be planned and discussed, as suggested already. Desaturation occurs quickly in an obese patient. Airway management can be difficult. You'll want all your tools to be directly at hand. Use of a ramped or sitting position is recommended as an aid to induction and to recovery. And I showed you the elevation pillows, a troop elevation pillow, or you can use a series of blankets. Drug dosing should be based on lean body mass and titrated to effect rather than dose to total body weight as a rule. Neuromuscular blocking, when used, you should incorporate neuromuscular monitoring, a train of 4 monitor. Depth of anesthesia monitoring using EEG can be very useful. We use the BIS monitor on the forehead. Prophylaxis against venous thromboembolism should be considered. Postoperative in ICU should be considered, but determined more by comorbidity and surgery than by the obesity per se. Those of you who want more information, here's an article from the Saudi Journal of Anesthesia from last year, perioperative preparation and pre-medication of the bariatric surgical patient. I bring that to your attention should you be interested in more information. Here they have this, again, the obesity surgery mortality risk score that I think can be very useful in ensuring that you know exactly the risks for your patient. Now, one thing that's changed the landscape in bariatric anesthesia is weight loss medications. And a variety of weight loss medications are available, and you can see some of them shown here, of which the GLP-1 agonist class of drug is among the most popular in the United States, although they're very expensive. Here you can see we're talking about $1,400 for this average retail cost, and a cost per dose of around $46 for this class of drug. So semaglutide is one particular drug, Ozempic, very popular, advertised on TV in the United States. And it's intended for type 2 diabetes, but in fact, the weight loss associated with this is making it very popular for weight loss in the United States. So there are a variety of clinics now that offer this as a product. And in fact, the Canadians who have lower drug costs compared to the United States often advertise that go up to Canada and buy your drug in Canada rather than the United States because of the enormous differences in cost. But there is a problem with this drug, and that is that delayed gastric emptying. And here is a report from this year, 2023, a patient who was fasted for 18 hours, but nevertheless aspirated on induction of anesthesia. And they're saying that patients with glucagon-like peptide 1 agonists for weight management may require specific precautions during the induction of anesthesia. And these precautions may require rapid sequence induction or awake intubation. But now the American Society of Anesthesiologists have made additional recommendations that these patients not be on the drug for a week prior to induction of anesthesia. Just how good are these drugs at reducing weight? Well, here's a study called the Step 4 Randomized Clinical Trial, published in the Journal of the American Medical Association 2 years ago. And this is a synopsis of how it was carried out. But let's take a look. So here is the mean change in body weight during the entire trial. So in the run-in phase shown in orange, up to 20 weeks, they lost weight down to around 10% of body weight. Then one group was switched to placebo and they gained weight again. And those that continued on semaglutide, they continued to lose weight. So the drug seems to work. And when switched to placebo, they gained weight again. Here is the mean change in waist circumference during the entire trial. And again, switched to placebo, their waist circumference went up, continued on the drug, went down. So remember that the American Society of Anesthesiologists recommend that you be off this drug for a week prior to the induction of anesthesia. And many people would do a rapid sequence induction or even awake intubation in some patients that they think can be complex. For more information, here is the guidelines for perioperative care in bariatric surgery from 2021 from the World Journal of Surgery. And the evidence and recommendations are under 4 categories: pre-admission, preoperative, intraoperative, and postoperative. Now, bring that to your attention for those people who want more information. They provide lots of information in terms of what drugs should be used and their level of evidence. Level of evidence for them is low. Recommendation guide is weak for some of these drugs like dexamethasone or statins or beta blockers. But what is interesting is here they say opioid sparing anesthesia using a multimodal approach. The level of evidence is high and the recommendation grade is strong. So this is a take-home point here. Opioid sparing anesthesia frequently valuable. In addition, there are some things that are recommended strongly, but the evidence for it may be weak. Increases in driving pressure resulting from adjustments in PEEP should ideally be avoided. And recommendation of the use of inverse respiratory ratio ventilation. Recommendations are strong, although the evidence at this point is still weak. So this is an article that may be useful. It includes the recommendations on muscle relaxation. And again, they recommend deep neuromuscular blockade, full reverse of neuromuscular blockade, and Sugammadex can be useful in that setting in patients who've got rocuronium. Objective qualitative monitoring of neuromuscular blockade improve patients' recovery, highly recommended. Now, let's move on to the problem of obstructive sleep apnea in such patients. So in this section, learning objectives are to understand the pathophysiology of obstructive sleep apnea, how OSA is diagnosed, describe scoring systems for OSA and how they impact on perioperative care. And there is recommendations from the 2006 American Society of Anesthesiology Task Force that many of you may want to become familiar with. So here is an article on obstructive sleep apnea from the journal Chest that you might find helpful, and it provides information that you may want to access for further review. They say that obstructive sleep apnea is a highly prevalent disease in the United States, affecting 4% of men, 2% of women, strongly linked to obesity, characterized by recurrent episodes of upper airway obstruction associated with reductions in ventilation, resulting in recurrent arousals, episodic oxyhemoglobin desaturation during sleep. Significant clinical consequences of the disorder cover a wide spectrum, including daytime hypersomnolence, neurocognitive dysfunction, cardiovascular disease, such as strokes, hypertension, especially hypertension, myocardial infarction, heart failure, metabolic dysfunction, respiratory failure, and cor pulmonale. So definitely has some side effects. The major risk factors include obesity, male gender, postmenopausal status, and age. So pathophysiology, absent nasal and oral airflow during sleep despite continuing respiratory effort, generally due to backward tongue movement and pharyngeal wall collapse, secondary to interference with the normal and coordinated contraction of pharyngeal and hypopharyngeal muscles. Enlargement of the tongue, tonsils, and adenoids are often contributory. One of the things is that we can get obstruction in the collapsible segment of the airway when the pressure exceeds the critical pressure below which airway collapse occurs. So this is the physics called the Starling resisting model of airway collapse. And it's illustrated here with compensatory neuromuscular responses with changes in upper airway mechanical loads. Signs and symptoms of obstructive sleep apnea you're very familiar with, and I mentioned them earlier. These are included for reference for you, but daytime somnolence and poor sleeping, loud snoring, commonly encountered, upper body obesity, commonly found. So the standard test for obstructive sleep apnea is polysomnography. It's an overnight test during which multiple physiological signals are monitored in the sleeping patient. And electroencephalography is carried out, electrooculogram is carried out, the submental electromyogram is carried out, and those related to cardiac arrhythmia, electrocardiography in particular. So there's multiple things that are transduced, and you get a recording such as this. This is a sample polysomnograph showing apnea periods with subsequent desaturation events. You can see the desaturation occurring here, then breathing again, desaturation occurring again. So the instrumentation shown here, they have electromyography, electrooculography, and electroencephalography, as well as transduction of flow through the nose and the mouth. So the diagnosis of obstructive sleep apnea, you find at least 30 episodes of apnea of duration at least 10 seconds in a 7-hour study period. Although it's often considered as a disease of adult patients, it's also common in children with tonsillar adenoidal hypertrophy or some craniofacial syndromes. Of course, airway issues show up, and here classification of the airway laryngoscopy. In patients undergoing general anesthesia, there may be increased risk of difficult mask ventilation and difficulty with tracheal intubation. Although predictors of difficult tracheal intubation remain controversial, high Mallampati score, 3 or 4, large neck circumference measured at the level of the thyroid cartilage, more than 17 inches, or more than 60 inches for females, and limited mandibular perfusion are more reliable predictors of difficult laryngoscopy than body mass index alone. And in one study, a retrospective case control study was carried out to examine the intubation issue. They found that the prevalence of difficult intubation much higher in the obstructive sleep apnea group than in the control group, 6.7% versus 3.3%. So you want to be prepared with extra equipment and even possibly an extra pair of hands. These findings do not imply that awake intubation is necessary, but prudence dictates that clinicians should have immediately available various alternative means to secure the airway, glide scope, intubating LMA, this kind of thing, or whatever is available on your difficult airway cart. And having an extra person available can be very helpful. So there's anesthesia concerns as well. Special concerns exist in the post-operative period when patients receive respiratory depression opioids for pain relief, something that I've already mentioned. Management options range from heightened clinical monitoring to the use of artificial airway devices like nasopharyngeal devices, which I find particularly useful, or carrying out induction and recovery in a sitting or semi-sitting position to minimize pharyngeal wall collapse. Now, as you know, and as I mentioned earlier, there are numerous predictors of difficult face mask ventilation. This is from the Langeron study, and you can see age over 55, BMI over 26, presence of a beard, lack of sleep, and history of snoring are all contributing factors. Now, in this particular study, they looked at postoperative complications at Mayo Clinic, and they found that serious complications occurred in 24% of the obstructive sleep apnea group compared to 9% in the control group. And so this study suggests that hospital stay has to be significantly longer in obstructive sleep apnea patients, and a mean, in this case, of 6.8 days compared with the mean of 5.1 days in the control group. So those of you who want more details, there's a guideline published by the American Society of Anesthesiologists, practice guidelines for the perioperative management of patients with obstructive sleep apnea, published in 2014. As well, they recommend the use of the Stop Bang questionnaire to predict difficulty with obstructive sleep apnea. And this is the questionnaire. And you have a high risk of obstructive sleep apnea if you answer yes between 5 and 8 questions, and low risk if it's 0 to 2. And this is commonly carried out in the preoperative evaluation process. And recommendations from this: they should work with surgeons to develop a protocol whereby patients in whom the possibility of OSA is suspected on clinical grounds are evaluated long enough before the day of surgery to allow preparation of a perioperative management plan. Perioperative evaluation. They have to decide whether to evaluate the patients based on clinical criteria alone, or where a sleep study might be more advantageous, but takes a long time and, of course, can be expensive. If the perioperative evaluation does not occur until the day of surgery, the surgeon anesthesiologist may elect for presumptive management based on clinical criteria, or a last-minute delay of surgery if they want to do formal sleep studies. And what about inpatients versus outpatients? Before patients at increased perioperative risk are scheduled to undergo surgery, a determination should be made whether the particular procedure is most appropriately performed in an inpatient setting or an outpatient setting. And in doubt, inpatient setting is preferred. Anesthetic considerations are listed here. Many of you are familiar with them already. General anesthesia, secure airways preferred to deep sedation. An endotracheal tube can be useful for a secure airway. Major conduction anesthesia should be considered for peripheral procedures. Unless there's a medical or surgical contraindication, patients at increased perioperative risk should be extubated while awake. Full reversal of neuromuscular blockade should be reversed prior to extubation, and use of Sugamadex can be particularly useful in patients getting rocuronium. When possible, extubation and recovery should be carried out in the lateral, semi-upright, or other non-supine position, and semi-upright is most commonly chosen. Discharge for criteria to unmonitored settings. They say that to establish that patients who are able to maintain oxygenation saturation levels while breathing room air. Respiratory function may be determined by observing patients in an unstimulated environment, particularly while asleep. So you want to keep an eye on the patient in this particular setting. What about the patients with CPAP devices? Preoperative initiation of CPAP should be considered, particularly if obstructive sleep apnea is severe, and many of the patients come with their own device. What about the use of sedative medications? Because of their propensity for airway collapse and sleep deprivation, patients at increased perioperative risk for obstructive sleep apnea are particularly susceptible to the respiratory depressant and airway effects of sedatives, opioids in particular, as well as inhaled anesthetics. And therefore, in selecting intraoperative medications, their potential for postoperative respiratory compromise should be considered. And this is why we often recommend minimizing the use of opioids in this setting. Regional anesthesia can be particularly useful, but suffers from technical difficulties in the obese patient, but this can be helpful when you use ultrasound placement. So let's close with a case for discussion and put a lot of these ideas together. An obese, sedentary 56-year-old man presents to the doctor with complaints of painful right knee, osteoarthritis of the knee, excessive weight, is considered and deferred to. An orthopedic surgeon confirms the diagnosis. After conservative treatment, such as cortisone and treatments and referral to a weight loss program and physical therapy, fails to improve the situation. The surgeon suggested that total knee surgery might be the best course. Patient wants general anesthesia for the procedure, does not want anything in his back, very scared of the use of spinal anesthesia, which in fact would be very desirable in many cases. About 5 years earlier, the patient was studied with polysomnography and found to have obstructive sleep apnea. Attempts at weight loss were unsuccessful, and as the obstructive sleep apnea continued, he was fitted with a nasal CPAP mask. Here are the clinical findings. 124 kilograms, body mass index of over 40, which means morbid obesity according to one classification, and blood pressure on the high side, as you can see here. Aspirin, 81 milligrams a day, multivitamins, but that's it. Allergies and intolerance is shown here, post-op nausea and vomiting problem. Quit smoking 5 years ago after 36 years, consumes alcohol, never felt the need to quit alcohol, no history of blackouts, never caught driving while intoxicated. Frequent bouts of chronic bronchitis in the past when he smoked, far less since quitting. Open appendectomy 12 years ago, complicated by severe postoperative nausea and vomiting. Told he was hypertensive, but took little credence in this since he felt perfectly fine. His obstructive sleep apnea was detected when he was investigated for daytime sleepiness. Family history: older brother died of myocardial infarction at 61. Father died MI at 47. That's considered a problem, of course. Review of systems, unremarkable, except as noted above. Physical examination, obesity, hypertension, Mallampati 3 classification, as only the uvula was visible at bedside airway examination. 12-lead electrocardiogram and laboratory investigations are unremarkable. So now that we have this background, what about some questions for discussion? What are the key clinical issues in this case? Well, obesity, hypertension, smoking history, alcohol use, Mallampati 3 airway, mask ventilation may be difficult, and obstructive sleep apnea is likely present in this case. What about the hypertension? Well, one question is, do you want to start beta blockers on this patient? And here are 3 different society recommendations from the American College of Cardiology, European Society of Cardiology, and the Canadian Cardiovascular Society. They make specific recommendations about blood pressure control, and they suggest target blood pressure ranges prior to the induction of anesthesia. So yeah, that needs to be treated. What about starting him on beta blockers? Well, beta blockers may be considered in patients with high risk of perioperative cardiac events. And remember, he has a family history of coronary disease. So that's definitely worth consideration. And they may be considered in patients with known or suspected coronary disease. Would regional anesthesia be better than general anesthesia in this man? Regional anesthesia is recommended as desirable, but often technically difficult and may be impossible to achieve, even with the use of ultrasound. But this patient specifically requested general anesthesia as he's afraid of having a needle in his back. Might mask ventilation be more difficult in this man? Well, yes. Remember the following criteria: 55 or over, BMI over 26, patient without teeth, with beards or snow. So snore, this patient would definitely be a possible difficult mask ventilation. Which muscle relaxant would you use for intubation? Well, it's a choice of rocuronium versus succinylcholine. And if the view at laryngoscopy proves to be unsatisfactory, what would you do? You can use external laryngeal manipulation, use of an airway introducer, switch to video laryngoscopy, or start out with video laryngoscopy. Many available options. In case of external laryngeal manipulation, left hand holds the laryngoscope, the right hand adjusts the position with external laryngeal manipulation. And then when the appropriate position is established, the assistant shown on the left will go and maintain that position for intubation. Any special perioperative, postoperative issues? Yes, as I mentioned, atelectasis, pneumonia, obstructive sleep apnea are all issues. Early mobilization is important. Adequate pain control is important. Pulmonary hygiene, important postoperatively. Sleep disordered breathing, consequences should always be considered in the obese patient. In the obese patient, increased risk of venous thromboembolic events due to immobility, altered blood flow, and other factors, and they'll very often get thromboembolic prophylaxis. So some resources that I would recommend for those who want more details from the recent literature from 2020 to 2022. These are available should you be interested. This brings us to the end of our discussion, and I want to thank you for listening, and hopefully I will be able to answer any questions that you have. So thank you very much, and I look forward to any questions that you might have. Again,
thank
I
you,
hope you
Dr.
enjoyed the
for this
presentation.
fascinating lecture. Thank you for your effort and time. We are waiting for your question from the floor. Anyone have a question?
Hello, Dr. Safa.
أيوة.
السلام عليكم.
عليكم السلام ورحمة الله. أيوة عليكم السلام.
Yes, أنا وسام.
وسام تفضل. معلش أنا آسفة مش شايفاك، أنا آسفة.
Hello, Dr. Safa.
Hello. This is my colleague, Dr. Wissam, will ask you. He is an assistant professor of anesthesiology in my department. He will ask you.
Hello, Dr. John.
Hello, how are you doing?
I'm fine. Thank you for your lecture. It's very valuable and informative. Actually, I'm interested in the field of bariatric surgery a long time ago. So it's very helpful for me to hear this lecture from a legend like you. So thank you. First, I have a question. In morbidly obese patients, COPD with obstructive evident obstructive sleep apnea, is it valuable to do blood gases for this patient pre-operatively?
If it's extreme and you're worried about hypercarbia, I think that could be useful, particularly for determining whether or not ICU stay is required postoperatively. So in extreme cases, an arterial line might be placed, in some cases awake, and then blood gas is drawn. Other people will rely on the CO2 tracing of the capnogram as a guide. But
I'm talking about the pre-operative preparation still, not in the OR. If I'm still evaluating the patient.
Yeah. So if the COPD is severe, then I think a blood gas reference would be useful, particularly when you're looking for hypercarbia.
Okay. Is there any end point for the CO2 tension? Like, when I should say this patient should be postponed, and we want to evaluate the CO2 level and improve it and improve the oxygenation of the patient, and then come for the operation.
So I'm not aware of any recommendations about pulmonary rehabilitation in this setting.
Yep.
Clearly, there are some standard things in terms of pulmonary hygiene. I would have to go through the literature and see if any specific recommendations have come that I'm not familiar with. In many cases, these bariatric patients are going for bariatric surgery, and the hope is that the bariatric surgery itself will provide an advantage in terms of their pulmonary status. So nothing that's published that I'm familiar with.
Okay. Actually, when patient comes to me in the clinic for preoperative evaluation, and I found him with severe obstructive sleep apnea, I'm asking him for blood gases. If I found the CO2 above 55, I just encourage him to use the CPAP preoperatively as long as possible, just to reduce the incidence of post-operative pulmonary complications.
I think that's a very wise thing to say. Yes.
Yeah. Good. I have also just I want to say that the nasopharyngeal airway is a very important tool we can use in such patient in the recovery setting. It's very helpful to keep the airway open most of the time, even if the patient is still not fully awake.
Yes, I wholeheartedly agree.
Yes.
It's one of the simplest things, but yet most effective things in the patient emerging from anesthesia. So I think you made a very important point there.
Yes. Thank you, Dr. John, for your valuable information. Thank you very much.
Excellent, thank you.
Yeah.
And don't forget, you can get copies of these slides should you be interested.
Yeah.
Thank you.
Thank you. Dr. John, please send it for me, and I will share it with my group, with my WhatsApp group.
Oh, sure. I'll be glad to send you a copy.
Thank you. I suppose, as regards the question of Hussam, that as you said, that the pulmonary hygiene is early stoppage of smoking and early physiotherapy and good aeration, exercise, all that will improve the preoperative pulmonary condition, and we can overcome the state of hypercarbia. Could be like, something like that. Yes.
You are right, Dr. Zafar.
We have a question, Dr. John, about the ventilation strategy. You said that the intraoperative protective lung strategy is used, and some of our colleagues ask about the ventilation. Do you prefer the volume control or pressure control in obese patients?
So typically I will use volume controlled ventilation with a relatively low tidal volume, as mentioned in the slides. You may have to increase the rate for CO2 control, but you do not want to give large tidal volumes if you can avoid it. And of course, the importance of the recruitment maneuvers, I've already emphasized, showing the studies on the various recruitment maneuvers available, and that can be very useful. In fact, some of the new ventilators incorporate recruitment maneuvers right into the ventilator. You can actually have recruitment maneuvers set up in some of the new anesthesia ventilators.
You can tailor the process, the intraoperative ventilatory as regard the patient condition and the comorbidity and the type of operation. You tailor the technique of ventilation. Or you insist in one method of ventilation?
Well, there are several publications showing various protocols. The one that I showed you is one of the more popular ones, and I would certainly start with that. You may have to make adjustments based on your clinical circumstances, and that's what we do, because we start off with a protocol and then we use our best clinical judgment to edit things, adjust things based on clinical necessity.
Yes. We have a question from our colleague: timing of applying recruitment maneuver during the surgery, especially laparoscopic surgery. Lung recruitment during during
So it's relatively easy to follow the protocols, especially if you do the lung recruitment by hand. When the oxygen levels drop on your pulse oximeter, that is a good opportunity to go and carry out the recruitment maneuvers. And my experience is that they're highly effective.
Also, we have a question about the usage of low tidal volume according to ideal body weight or real body weight.
It was ideal body weight according to the protocol I showed.
Yes.
And that's a starting point because, of course, you're going to be making adjustments based on your clinical experience.
Yes. Yes. Dr. John, I have a comment, please. Does the body mass index still working well for assessing the obese patient, or we may have another issue to assess this obese as regard the moderate and the morbidly obese one? It does go with us in these days, or we may have another issues to assess the obese patient?
So there are a number of metrics that have been offered to assess the obese patient. Before body mass index, there was an indicator called ponderosity index, which has now fallen out of favor, and body mass index is the one that is commonly used. The other problem is that you have some people who are quite healthy and have large muscle masses who have an elevated BMI, but it's because they are athletes, for example, wrestlers who have much muscle. And so you can have people who are, according to BMI, are obese, but in fact are not. And other people might recommend in special circumstances that we use the thickness of the fat in the abdomen and the abdomen waist measurements. So certainly BMI is a good starting point, but in special circumstances, there may be other things you may want to take into account.
As regard the obesity paradox you mentioned, sir, in this lecture, it have a relation with the ICU survival in obese patient.
Yes, it's so the ICU survival paradox shows that at a moderate obesity may offer an advantage compared to people who are undernourished and have a low BMI, or the patient who has extreme BMI, typically over 40. This is a subject of ongoing research to find out what exactly is going on. How could the obesity be protective in some way? And it may be that this is an artifact of the data because it includes many patients with chronic obstructive pulmonary disease who have lower BMIs. And so I'm awaiting studies that would control for obstructive sleep apnea, for COPD. We'll see how that plays out as further studies are carried out.
Yes, it is a matter of the obese with the comorbidities, or the matter of the undernourished people with their nutrition deficit and etc.
Exactly.
What will waive the ICU survival and the length of stay in the ICU?
Correct.
We have a question here about the mode of ventilation, pressure control, or volume control for obese patients. Is it really better than the volume control, or there is no difference?
So I don't know of any study that compared one method with the other. I have only my clinical experience to go by. And so low tidal volume ventilation is what I typically do and what's recommended. But there's also pressure ventilation or pressure support ventilation with volume guarantee that's offered by some anesthesia machines. That's an interesting question, but I think it will await further studies comparing one with the other.
Yes. Please, Prof. John, as regards the heart failure, the right ventricular heart failure on obese patient with pulmonary hypertension, etc., can the obese patient overcome this state of heart failure more better than the lean one or the undernourished one?
A very good question, but no answer for that without further studies to understand
is it
the
a part
underlying.
of obesity paradox? Is it a part of obesity paradox?
I think it's related to it, yes.
Yeah.
But I think you'd have to talk to someone who was actually involved in the studies and the design of the studies to find out further insights into it.
Yeah. We have a question about the IE ratio in this patient, the inspiratory to expiratory ratio during intraoperative ventilation. What do you recommend, sir?
One of the slides showed that inverse ratio ventilation is sometimes useful, but I think that would depend on your clinical findings intraoperatively. So I would start off with conventional ventilation and make adjustments looking at things like airway pressures and the capnograph waveform to make my adjustments.
Yes, yes. Someone who have difficulty during the IV access, and as we are in low resources countries, we have the ultrasound to have this access. What do you advise us to do to have an easy IV line?
So there's a couple of easy things that can be done. One of them that's easy to do is to warm up the extremities. So we take the blankets and we warm them up, and then we put the hand in the blankets, both left and right. And when the hands get warm and the arms get warm, you get a vasodilatation effect. And that's a simple thing to do. It requires little in the way of resources. You can even use the blankets for the ramping of the position later on. So that's the easiest thing. There are other tools available that are expensive.
The dominant hand, because it is working and may have enough venous exit, the dominant hand.
I use whatever hand provides the best best access, but hands are our usual choice, or arms. We avoid the antecubital fossa most of the time.
Actually, I have an experience in such IV lines. We can start with a small IV line in anywhere, especially maybe in the distal forearm in the vulvar surface. And then after putting the patient to sleep, the vasodilatory effect of the inhalational anesthetics dilate the vein more and make it more obvious, and we can insert two more IV lines.
Yes, that is an excellent suggestion. You can just have an IV to get the patient to sleep, and then the vasodilatation allows for a subsequent IV. And it's always nice to have more than one IV.
And you know, before it was a routine in the old time. It was a routine to insert a central line for such patients. But nowadays, I think a couple of IV lines do the job.
Yes.
Well said. Central lines are dying outside of cardiac and thoracic. It turns out that, and this is a subject of another talk, but measurement of central venous pressure is not as useful as we anticipated. But in terms of a place to give inotropic drugs, it remains our preferred location.
The best. Yes, you're right.
Yes. For me, I am refusing to have some patient technically difficult, and I have no rule, and I will use thromboprophylaxis post-operative. So what for? We have a question, Professor John, about the usage. Is the usage of IVC, the inferior vena cava filter, for those with high risk who planned for major surgery?
So I'm not sure I understand the question.
Safa asked about the routine usage of IVC filter in obese patient for major surgery, obese patient and IVC filter.
Typically, they're not IVC filters are not put in routinely. They can be put in under special circumstances. But pharmacologic prophylaxis is commonly done. And very commonly, this is simply 5,000 units of heparin given into sub-Q in the deltoid area. That's commonly done, but it depends on what the hospital protocols are, because hospitals vary in how they handle things, and surgeons have varying preferences as well.
It has its hazards, and it only can be used when we have contraindication to pharmacological thromboprophylaxis. We can use it in high-risk patient. Maybe.
Well said. Yes. Yeah.
Yeah. Atrial fibrillation.
I think yes.
Pulmonary, etc. But for no.
I think we can think about the IVC filter in patients with repeated DVTs or previous history of pulmonary embolism, like that. But
if the patient have surgery, have whatever. Yes, we can use it.
Yes, but actually there is no recommendation for IVC filter, routine IVC filter for
because it's unique hazards. Dr.
Assalamu
Hani,
alaikum.
have a question? Dr. Hani?
Yes, assalamu alaikum. First of all, thanks for Professor Dr. John for this amazing lecture. I would like to ask about pre-induction in this obese patient regarding respiratory derangement in this patient. Do you recommend to use continuous usage of nasal bronch or high flow nasal cannula to avoid induction hypoxia in case of cannot intubate? Secondly, if this patient we decide to do awake fiber optic, and he refuses, what other decision?
So the first question is the use of the high flow nasal oxygen or Thrive. And my experience with it is that it works amazingly well. Typically, it would be humidified oxygen at a flow of 50, 60 liters per minute. I use it quite commonly for our ENT procedures, and it is remarkable how well it works, even in the obese patient. So that's a very good point. And in fact, Thrive is worthy of an entire lecture on its own, as it's changed the way anesthesia is done and displaced the use of jet ventilation, where some places use jet ventilation only rarely now because Thrive works so well. The second question you ask about the patient who refuses awake intubation, what to do? There's no good answer. If it's an elective case and you're worried that you're going to have a real mess on your hands, you can refuse to do the case. You can simply say it's a risk I'm not going to agree with because it's going to result in disaster. A similar situation occurs when you have a parturient who says, I don't want a cesarean section under any circumstances. And the obstetrician may say, well, if that's the case, I can't be your doctor because I'm not going to let the baby die unnecessarily. So it's a question of ethics. And people will vary, and it will vary by culture. So what's might be appropriate in the United States might not be appropriate in, for example, in Egypt. I just hope I never get into that situation. But one of my early mentors, Dr. Ovasapian, who started the Society for Airway Management in 1995, he discussed that specific scenario. And he said, listen, I'll start off with gentle anesthesia. And if at any time you say stop, then I'll stop and then we'll regroup. So he got the confidence of the patient by ensuring the patient that if there's any difficulties, that he would stop, add more local anesthesia, add more sedation as appropriate. And he said that works most of the time in patients who would otherwise refuse awake intubation.
Yes, thank you. Regarding the recruitment maneuver, the best way to increase the arterial oxygen tension at the end of the surgery because of intraoperative occurrence of atelectasis. If we have a patient and still the patient have hyperinflated chest and COPD, and we are afraid of this high pressure to cause such pneumothorax in complication, this is still the best way to increase the arterial oxygen tension.
So the thing about the recruitment maneuvers is that they're often carried out in a setting where you're using lower tidal volumes, and then you are ventilating at a somewhat faster rate. But when you do the recruitment maneuver, you go up to 40 centimeters of water. It's not done for a long period, it's done for 15 seconds. The worry about inducing a pneumothorax is present, but I'm not aware of any pneumothoraces that have been induced in that particular setting at 40 centimeters of water. So I'd have to review the literature to see if there's any complications associated with the recruitment maneuvers that are commonly used, but I'm not aware of anyone who's reported a serious trouble as a consequence of using the recruitment maneuver. But that would be a matter of reviewing the literature and seeing if any case reports have been established.
Okay, thank you. Thanks, Dr. Thanks.
We have another question about the recommended dose of sedative agent for day case surgery or additives to regional anesthesia can be used.
Can regional anesthesia be used for
sedation? If the patient have a day case surgery and have regional anesthesia, and this obese patient, the anesthesiologist want to give him sedation, what the maximum dose and the recommended drug for sedation?
So recommended drugs for sedation will vary depending on where you are. For example, in some settings, dexmedetomidine can be very useful for sedation because it keeps the respiration intact compared to opioids.
Yes.
So there's a number of people who would recommend that in particular. The problem with dexmedetomidine or Precedex is that it's expensive. And so it may not be something that would be your first choice. My experience with dexmedetomidine in the very obese patient has been quite favorable. And I've used it in this setting.
Yes.
When other drugs would be especially problematic. Sedation using benzodiazepines can be used, but they tend to impair respiration. But remember that they can be reversed with flumazenil. And even the opioids can be reversed with naloxone, but we tend not to want to do that. So dexmedetomidine, very good drug for that setting, but unfortunately expensive. Somebody asked about what about remidazolam? That's a drug that is now becoming popular in the United States. Those people that have used it say that it's amazing because it's short acting, but a lot of hospitals do not permit its use because of the high expense. So I would wait to see if your hospital makes it available. Many hospitals in the United States simply say it's too expensive a drug and we're not going to make it available. But it is popular in some places in exactly this kind of setting.
Yeah. Yes. What about the remidazolam? Remifentanil
Yes,
plus remifentanil, I think, plus midazolam.
So there's remimazolam is popular, but it's very expensive. Remifentanil can be used as well, but it too is very expensive, and a lot of hospitals discourage its use. I particularly like it for ENT cases where I'll do propofol and remifentanil together as 2 infusions, because you have the kind and gentle wake up that is so nice to have for ENT procedures.
Yes. Prof. John, does the optimum time to extubate my patient, like the non-obese patient, or I should have some consideration before I extubate my patient? All of the time we have difficult intubation. So I may keep the endotracheal tube for a late time, even if the patient be fully recovered. Sometimes we have, I'm so sorry, I will complete my sentence. Sometimes the eye surgery and neurosurgery, we have to have a smooth extubation to have no pucking or coughing on endotracheal tube. How can we solve this issue?
So the question is, how can you get smooth extubation for neurosurgical procedures, ENT procedures, eye procedures? When I do that, for that, I use remifentanil.
Yeah.
That's my go-to technique. And I extubate on low dose remifentanil, and it works remarkably well, but not perfectly for everybody. Some males still wake up in a turbulent manner, but I'm guessing it will be even more turbulent if alternate technique were used. So for a kind and gentle wake up, such as you describe, remifentanil is my go-to drug.
Yeah, you cannot transition between the deep extubation by having eye gel or laryngeal mask as a transition step.
So that's another technique that can be very helpful. So you extubate deep, you put in an eye gel. That's my preferred device. And then you wake them up on the eye gel. And that works quite well. The problem can be, of course, it's more expense. And in patients who have, who you're concerned about gastric emptying, that's less of a valuable choice. But I've done it a number of times, and it's often when I'm concerned about turbulent emergence from anesthesia. The other thing that some people do is they let the cuff of the endotracheal tube down, and they squirt lidocaine down the tube, do some ventilation with the cuff down so that it spreads lidocaine under the cuff, and then reinflate the cuff. And then they wake them up with anesthesia under the cuff, and that provides for a better wake up. I'm not sure of any studies that have evaluated it, but it's one of the techniques commonly taught.
Yes, or inflating the cuff with lignocaine, is it working good?
You could put lidocaine into the cuff, but I haven't, it has to seep through the cuff, and I'm not sure how well it works in any studies.
Yeah. At the same time, I would love from your own experience, Prof. John, about the usage of eye gel or laryngeal mask in difficult intubating patient, especially in laparoscopic surgery. Do you agree with me that is could be harmful maneuver, especially if it's susceptible for aspiration or potentially full stomach patient?
So for full stomach patients, it's common for us to do rapid sequence induction, but if we are worried about a difficult airway in that setting, then it's common for us to just do awake intubation.
Yeah.
And that works well, but you have to have enough experience with it, and you have to have a team of people to help. But if a rapid sequence induction is not a wise course, then we'll do awake intubation. And in some cases, we'll do regional anesthesia where appropriate.
Yes, but if your patient is prepared well and he has an empty stomach, can you complete the procedure by laparoscopic surgery? I mean, by eye gel or laryngeal mask?
So I've seen that done, but I've never done it myself. So for most laparoscopic procedures, because of the positioning and the high intra-abdominal pressure, the awkward positioning, I tend to avoid anything other than an endotracheal tube.
I completely agree. We have we have a question again. I'm so sorry for annoying you. To prepare the patient for extubation through eye gel, it is better to use gastric tube as well and prepare atropine, maybe for secretion.
So for secretions, I tend to use glycopyrrolate instead of atropine. But more commonly, unless there's extreme problem with secretions, I will put a nasogastric tube or orogastric tube down, suction out everything, and then take it out while the patient's asleep. And then we'll have our Yanka or sucker that will go and get rid of any secretions. Occasionally we'll use glycopyrrolate as long as the tachycardia is not a problem. We tend not to use atropine, but atropine would work.
Yeah, yes, yes. So when opioid is a necessary or mandatory for a patient with major orthopedic surgery or the operation with severe post-operative pain, when opioid is may be mandatory for such patient, and we should use what drug you would choose from opioid?
So in this particular setting, it's common for us to use patient-controlled analgesia, where they can push a button and give themselves a small dose. The popular drugs in this setting are fentanyl, 25 micrograms at a time, with a lockout of 6 minutes. And another popular drug is ordinary morphine, 1 to 1.5 milligrams with a lockout time of 6 minutes. And other drugs are available as well. But patient-controlled analgesia provides the flexibility that allows for good pain control in these patients. But there's many other techniques that are used, including regional anesthesia, as well as various blocks that are available. Examples for abdominal surgery being tap blocks.
Yes. Professor, you mentioned that as regard the weight loss medication, we have many cumulative drugs for loss of weight, maybe herbal drugs, etc. What are the warning precautions and your warning signs for us as anesthesiologists to aware about certain drugs or certain herbal that used for weight loss?
Well, the big one now are the semaglutide type drugs, which are very effective for weight loss, are intended for use for type 2 diabetes. And these drugs, although they're very expensive, are still in fairly common use in the United States. But now that we are experiencing episodes of aspiration on induction of anesthesia in patients who would ordinarily be fasted, we're learning that it's important to be off these drugs for a week beforehand. And of course, if it's an emergency, you may want to do awake intubation.
Yes.
Or rapid sequence induction.
Yes. I know you're interested in nanotechnology, and you are working hardly and tirelessly in this issue in nanotechnology. In obese patients, should we have more studies about the targeted therapy as bupivacaine, liposomal bupivacaine for analgesia, etc.?
So a lot of centers are using liposomal encapsulated bupivacaine. It works well, post-op wounds in particular. The major drawback being it's very expensive.
Yeah, yes. And not available in more than our countries. It is not available at all. As regard the fluid management, Dr. June, do you prefer fluid restrictive maneuver or liberal fluid as, or it depends upon the type of surgery?
Oh, it'll certainly depend on the type of surgery. And that question is worthy of a whole 2-hour talk in itself. It's a very interesting question, liberal versus generous fluids. What is the index that we would want to use to assess volume status? And the other question that comes up is liberal versus generous versus restricted use of blood transfusions. And that issue is coming up in trauma patients, for example. So as the literature on that evolves, perhaps I'll give another talk on some of those debates because they're interesting, and the information is becoming published every time the American Society of Anesthesiologists have their annual meeting. There's new reports that attract our interest.
Yes, yes. As regards the case scenario you mentioned in the end of the lecture, this obese patient for total knee or whatever the maneuver for his knee, this patient you mentioned that he has his father and his brother have MI. We should know from that they are for the familial hypertriglyceridemia or hypercholesteremia, familial hypercholesteremia.
So that's a possibility, particularly the type 4 hyperlipidemia. If I were the family doctor for him, I would recommend further investigations. And another thing that could be helpful is a treadmill test to see if there's any signs of coronary disease that can be remedied by intervention, such as the placement of a coronary stent. So this is a complex patient, and there's a number of additional issues which we would love to have a chance to take a look at.
Yes, and you mentioned in the same patient that he had severe post-operative nausea and vomiting when he was 12 years old after appendectomy. And of course, there is some studies about under the age of personalized or precision medicines that gene may be responsible for the post-operative nausea and vomiting. You suspect this patient may have, after general anesthesia, to have the same condition?
So that's an interesting thought. What you'll find is that most people will simply say, I expect it to be a problem, and they will give an antiemetic during the case, perhaps even a second antiemetic, and ondansetron would be the first, granisetron might be another choice, and then decadron being another drug, and then a whole pile of options for post-op care. Scopolamine patches are commonly done as well. And it's not uncommon when we have this kind of problem that we avoid the use of vapor such as sevoflurane and do a propofol anesthetic.
Yes, I understand. Also in this patient, if he insisted to have general anesthesia and I have all such a problem, how I convince him by regional technique, what is the best way to explain for my patient and try to convince him that regional anesthesia is better for you? You will have early ambulation. You will have early intestinal movement. You will have low usage of thromboprophylaxis, etc. with regional anesthesia, and you have prolonged post-operative analgesia. For this patient, what are my opportunity to explain for him that regional technique is preferable for you?
Yeah, so you've outlined the key points to bring to the attention of the patient. In addition to those points, you simply want the patient to trust you. If the patient trusts you and likes you, then they're more likely to
yes.
yeah, to agree to a plan.
I think we have the last question about usage of I don't know what is this drug. I don't know how to read it. Wissam?
Oh, it's a combination of bupivacaine and meloxicam.
I don't know what this drug I read.
Yeah. So I haven't seen that used. I know that it's available. Like so many things, you'd want to see what studies have been carried out, but I haven't any experience with it. And one of the problems with these is that a lot of hospitals restrict the use of these drugs because of the extreme expense. And as the drugs become more commonly available and the prices drop, clinicians will get more experience with it. But meloxicam can be a very good non-steroidal for use for pain management. Not everybody likes it, but that's true for all the non-steroidals.
Yes. Anyone have a question from the floor? Anyone have a comment? Yes, we reach the end. All of my appreciation and greeting for you, Professor George, for your time and effort. Thank you. And hoping to see you again after October, inshallah.
Okay, well, I'm looking forward to my visit to Abu Dhabi in October.
Yeah.
And
yeah,
of course,
I'll meet
I'm looking
you.
forward to more opportunities to present to this wonderful audience. Thank you
Thank
very
you.
much for your time and your attention.
Thank you. Thank you for your
Okay.
time and effort. Thank you. Thank you
Okay.
for support for the Egyptian Society of Anesthesiology and Acute Care program, online program. Thank you for your elegant and unlimited support. Thank you,
Okay.
Professor. Thank
Until
you.
later. Okay.
Have a good
Bye-bye.
time. Have a good time. Goodbye.